Okay, Claire, I think we can get started. So if you'd like to start us off briefly, I can take over.
Sure. So welcome to the first week of the fall 2023 ECHO Clinic, Health Equity and Cardiovascular Risk. We appreciate you all joining us today. Remember, so during all case discussions, we are discussing real people, but we ask that you don't use any personal health information when you're discussing your case. So this could be the obvious PHI names, all the numbers, or even something like a specific place where they work. So no one knows who you're talking about. Go ahead, Rick, next slide. The chat feature will always be live during the meeting. So if you ever have any questions, feel free to chat the group or any comments on what's going on. Mute and unmute during question and answer. This is meant to be a collaborative kind of group effort. So we encourage participation. And then the next part is names, numbers, people to contact. So if you ever have any tech questions, Zoom questions, anything like that, Rick is our IT support. That's his email and his phone number. I'm Claire. I'm coordinating the clinic. You've heard from me through email. That's my email address and my cell phone number as well. I will be going out on maternity leave sometime in the next month. So Andy Christopher, who is here with us today, will be taking over at some point. And there's her email, but not her cell phone because I didn't ask if I could put that on there. And then Gotham, Dr. Rao is our facilitator with his email as well. And he can always answer any questions you have. Next slide, Rick. Gotham, when do you want to take over?
Yeah, sure, that's fine. So I want to thank everyone for joining this particular series. So this has evolved quite a bit over the last couple of years ago. And we started off with a very medical type of series on cardiovascular risks. And then it evolved into considering social determinants of health. And this fall, we're very focused upon health equity and cardiovascular risk. So all the sessions that you'll hear, including Adam's session this morning, will focus on that particular issue, including some foundational issues as well. So Cardio was founded in 2017. So it's an initiative funded by Ohio's Medicaid population, especially Medicaid department, rather, especially to reduce health disparities within the Medicaid population. It's an initiative across 7 medical schools in Ohio. And so we identify, produce, and disseminate best evidence to improve primary care practice, but just dissemination, of course, doesn't have a lot of impact unless there are mechanisms to implement it. And this is one of those things. So this is formal case-based education. And for those of you who did go to medical school or pharmacy school or whatever, you remember cases much more than the actual didactic lectures and things when it was presented in a much less contextual fashion. So we have a library of resources on our website, newsletters, and of course, many other resources, including this ECHO training model. Next slide, please, Rick. So this is the ECHO team. I'm the facilitator. This is, I think, about my 4th year of doing this here in Ohio, but I was the ECHO director of the University of Chicago for 8 years prior to that, and I've done over 200 ECHO sessions. We have a number of experts here. Adam Perzynski is going to be speaking this morning. And you'll start, I'm not going to introduce everybody, but you'll start to meet some of our experts as they go through their sessions and as they make comments as well on our particular cases. Next slide. So this gives you an idea of the geographic range of participating sites. You can see the whole state is relatively well represented, including southeastern Ohio, which is caters to a lot of rural communities. That's Ohio University, but also, of course, our urban communities in Columbus, Cleveland, Cincinnati, and Toledo. Next slide. And this is just a list of our participating sites. Next slide, please. And today I'll be facilitating, as I will every single week. Adam is going to be presenting on issues that are relevant actually to health equity. I'll be presenting a case. Now, the case I'm going to present is a sample case. It's a real case. And I was telling Claire, I may sound frustrated as I read this through because it was a patient I saw about three hours before she actually asked me to. She sent the email asking for a case. So I filled it out right away. And everybody's going to be able to comment on this, including our subject matter experts, but it'll give you a flavor of how cases are generally presented and how they're discussed. Next slide. These are our disclosure statements. You can read these, and if you have any questions, you can contact me or Claire or Anderson, Andy rather, anytime you wish. And the folks can actually give you an overview of what their disclosure means. So Adam this morning is going to give us an overview. I think that's going to set the stage for the next 12 weeks or so. So Adam, please take it away.
Great. Thanks so much, Gautam. I was reflecting on how to share this morning, and I was thinking, well, how do you talk about 100 years of health equity research and cardiovascular health in 15 minutes? And then I'm like, well, you probably don't. So I think one way of thinking about this is I'm sort of giving some highlights that I would bet that many of you have heard before, some conceptual definitions, some shared vocabulary, and then giving you some insight into some of the cardiovascular risk and health equity work we've done here in Northeast Ohio, and then sort of like providing maybe some provocative questions that may serve as nice reflection point for all the cases throughout this series this time, which I'm really excited to hear the cases. A lot of my work is on case-based learning, so ECHO might be one of my favorite things in a year. Like these weeks are like things that I just really, really look forward to. Oh, it looks like Rick, you gave me little arrows so I can control these two. Thank you, that's very nice. So we're going to define health equity as it pertains to the care delivery system. I'm going to give another objective is for you to be able to think through some examples of how subpopulations are disadvantaged in their cardiovascular risk. And then we'll maybe reflect on some strategies of what social determinants of health look like. So this first question is, what is health equity? Well, I think there are many places you could go for a definition. This one is really Centers for Disease Control authored statement. And I think it's a nice, fair approximation of what you would see if you searched across a lot of different literatures. But I like the idea that it's a state in which everyone has a fair and just opportunity to attain their highest level of health. The one thing that I might add in here that appears in some other places is just like 2 additional words. I would add the 2 words "and dignity." So a fair and just opportunity to attain their highest level of health and dignity, because I think sometimes that gets left out of our processes that are targeted at health in the care system especially. And so I think this is really, we're talking about care system a little bit today. So I think that's a fair definition of health equity. The other concept that is intimately linked with health equity is the concept of health disparity, and you saw it in the bullet points on my prior slide. And the healthy people definition here is quite good. It's a particular type of health difference. So I'm thinking that there are lots of health differences across individuals and subpopulations, but there's a particular type of differences that is connected to social, economic, or environmental disadvantage. Social there could also be cultural. And I think so health equity cannot really happen as long as we have ongoing health disparity. This is something that generally affects groups of people who have experienced some series of obstacles to health. One of the most important distinctions that I like to make is a distinction between health disparity and health care disparity, where the first refers to the burden of illness, injury, disability, or mortality. So thinking about like health outcomes or the burden of disease, so we might have differences between groups or subpopulations or nations or counties or neighborhoods or cultures or other identities that we would call a disparity. But a care disparity often feels a little bit worse or a little bit more nefarious to those of us who work in healthcare, because it refers to differences in things like coverage, access, use of care, quality, and safety. And the other way that I like to refer to this is like, this is the stuff that happens in the building and on our watch as healthcare professionals. And it might be related to our processes of care or the way we operate our care system or our clinic, or even the way that we interact with our fellow coworkers or our patients can end up being manifested as care disparities. I spent so many hours on Google image search over the past 3 weeks trying to find the perfect figure for this slide. There are many of them. So if you just want to do your own, like cardiovascular disparity or cardiovascular health equity differences, or cardiovascular equity risk equity gap, you'll get thousands of images that have been published, really mostly in the past 20 or 30 years. So, and generally they focus on this 20-year timeline, and there might be many that are not based upon race or ethnicity or sex or gender or age. This is one that I found that captured some amount of the information by age and by race and ethnicity and by sex. And I think it's a fair depiction of equity gaps. And there are some interesting things going on here. One is that you see a spike in the burden of cardiovascular, adverse cardiovascular outcome among American Indians and Alaska Natives over the past 20 years. That is actually shocking and alarming among younger and midlife people. The other thing that we see is that we see those lines going up for almost everyone in the bottom left pane, such that like we're doing worse. And that's not a great feeling overall, right? So the burden of cardiovascular outcomes is doing worse. This one is, they described as hypertension related for this specific figure. If you look at how they calculated it, though, it's really mostly all-cause cardiovascular death. And then the most striking gap here is the difference between African Americans and other races and ethnicities over the past 20 years. There's another figure that I didn't place in here, which is important to think about, which is if we extended all these to the left, right? Like if we went back another 30 or 50 years, what we would see is a really, really steep decline for all groups. So coming into the year 2000, the rate of decline of cardiovascular death is dropping drastically. But then we sort of hit this spot around the year 2000 where we sort of plateaued. It looks like the gap is still narrowing a little bit for older African Americans there in 2010, but then now we're sort of maintaining and increasing equity gaps over the past 20 years. Is one way to. So the other way of thinking about disparities in equity is that they don't occur in a vacuum. Like these differences, they're in a social context where we have inequality in our society. We have many and rampant inequalities, and I'll highlight some of those in just a little bit. The other main concept here is that these are avoidable differences. So these are things that we presumably could avoid by improving our systems of care, by developing more equitable systems of coverage and access, by providing communities with the tools they need to live healthier. And then this last point that I really want to just stare at a little bit is that bias, stereotyping, prejudice, and clinical uncertainty contribute to disparities. And so even today in 2023, there are still we'd like to talk a lot about sort of structural influences, but we also have interactional and interpersonal influences that generate disparities and present a barrier to equity. this is another CDC statement, and it's like one of their first sentences, which is that health equity benefits everyone. And I really love this quotation, so I like to read it aloud in full. Every person who dies young, is avoidably disabled, or is unable to function at their optimal level represents not only a personal and family tragedy, but also impoverishes our communities and our country. We are all deprived of the creativity, contributions, and participation that result from disparities in health status. There's a sociologist by the name of David Williams at Hopkins, who's been writing and talking about health disparities since really before anyone else was. They sort of started the first center on eliminating health disparities in the country many years ago. And when Dr. Williams talks about this, the last time he was in Cleveland was quite a while ago, but he gave this very graphic example of the burden of health disparities in cardiovascular disease alone. And it's very graphic, and I have mixed feelings about it, but I'll share it with you today anyway. And if you look at those numbers that I showed you, the 20-year chart, that difference in mortality is the epidemiologic equivalent of taking a 747 airplane to Cleveland Hopkins International Airport, filling it with African-American residents over the age of 35, taking it off and crashing it into the end of the field every day for the past 20 years. Like, that's the difference in cardiovascular mortality by race and ethnicity. It's a shocking and horrible statistic, right? Like, it looks like just a gap on a chart. David really is not happy with that particular gap. And I think his illustration is better than the figure. It's also a little bit gruesome and awful. But one of the reasons he talks about it in that particular manner is as a little bit of a wake-up call, because think if that's what was actually happening, is like how outraged we would be on a day-to-day basis, right? And then the one of the things that stumps him is the lack of outrage on a day-to-day basis when that sort of grind and slow risk and slow death of communities is happening. That we can trace that difference and other differences to a set of structural determinants, and one of those would be structural racism, which is that while we might have interactions and interpersonal differences that look like racism, those across institutions and across our society that have been compounded over decades are some of the most nefarious. And I'm going to give some quick examples of that from our own work here in Northeast Ohio. This is a nice just overview of how we end up in a place where we have differences. We sort of a mucky pond of day to day where we have disparities down at the bottom. And one of the ways is that we have these big social environmental differences and challenges, but then in the middle of those, we have a lot of really important concepts that happen largely at our neighborhoods. If you look at these midstream variables, most of them happen at the level of a county or a neighborhood. Whether you're being exposed to differential air quality, whether your housing is insufficient, whether you live in a place that doesn't have access or affordability of healthy food, whether you're somewhere where employment opportunity figure, which I really like because it places racial disparities in particular in a very, very clear social historical context that includes contributions of health and medical professions in sort of the top left when we think about differences in training practices, right? So there's still a poster in the hallway outside the building I work at Metro Health that celebrates the first African-American medical resident and celebrates the fact that at his first day of residency in our hospital many years ago, no one was sitting with him. He was the first Black doctor in our hospital, and he went to have lunch and he had to sit by himself. And that was less than 100 years ago. that was happening in our hospital. And we celebrated it because Metro Health in Northeast Ohio was the first place to have a resident who was African American. But on the other hand, it also feels a little bit grim and recent, and that we haven't necessarily overcome all of those challenges and barriers. I'm going to shift gears to some of my own work a little bit. And so this was a paper that we wrote after talking with a group of Black men in Cleveland and the women who cared for them. It could be their adult daughters or their wives or girlfriends. In one case, it was a sister. And we were really generating a cardiovascular risk reduction intervention for these men. So talking to them about, like, how can we do the things that would help you after they'd all already had a stroke, that would help you reduce the things that would have a recurrent stroke. If you're not aware, the rate of recurrent stroke among younger Black men is approximately 8 times that of any other group. So it's a very, very severe burden of recurrent stroke. And so we went around the table and talked about the barriers that they encountered. And we had talked about, how do we generate programming and behavioral modification approaches that would help you do these things on this list, basically, the life. And what we heard were some really interesting comments. And one of them I've called out here. I focus on what's going on with African American men. And one of the things why we're having so much stress, I think a lot of stuff is dealing with stress and social issues. When you start talking about it towards African American, the stress got to be at least 75 to 80% of why we even had a stroke. So their logic is that if that stress in their lives is still there, after they've had a stroke, of course they're going to have another stroke. There are some other very interesting comments in here that provide a lot of perspective. I grew up on soul food all my life, and it's kind of hard for me to change as a barrier to salt restriction. There's one in here that I always want to read, which is, sometimes I think of the doctors as just using us as a paycheck. If you get sick, you're going to go see your doctor. Who gets paid? Your doctor. If they write a prescription for you, they get kickbacks. And I think this is a common misperception. I work in a hospital. I don't know any of my clinical colleagues who get any kickbacks on cardiovascular risk reducing medication. Part of me, the behavioral economist in me, sort of feels like maybe we should try that and we would actually do better. But the idea that our patients are still on a day-to-day walking into our clinic, and they're fearful that there is this economic incentive loop back, and that our discussing and working on cardiovascular risk reduction is not about the disparities gap, but it's about maximizing earnings for clinicians, is really disheartening. And it honestly, like, sickens me a little bit. We're all working so hard, and yet we're so disconnected from our communities that our neighbors who are coming into our clinics are still thinking that we're kind of out to get them and extract resources. We have this extractive system where we're extracting resources. One of the reasons people might also think that are maps like this is a map of Cuyahoga County here in Northeast Ohio, where we have 2 panels. The panel on the left shows life expectancy with a gradient from 65 to 85 years. And what you see is this pattern where folks who live in the most urban neighborhoods that tend to be populated by racial and ethnic minorities, particularly African Americans, have an almost 20-year gap in life expectancy. That 20-year gap maps almost perfectly to differences in neighborhood socioeconomic position in the right-hand pane. This is some work that that life expectancy data comes from the Centers for Disease Control. So some work from my team that is just about to be published. What we did is we took 500,000 people. So instead of using estimates from the Centers for Disease Control, we used electronic health record data from our local health systems over the past 15 years. And we looked at the life expectancy gap, not overall, but within each 5-year increment of age after the age of 40. And we see these massive, massive differences across all age groups with a sort of reduction. It's like if you make it to 90 or 95 years old, we have health equity. But before that, we have a really large life expectancy gap, and the green and the red and the blue here are between neighborhood socioeconomic position. So the highest and the lowest socioeconomic conditions of neighborhoods. You also see a really sort of awful spread for low socioeconomic position men with very high variability, right? The top right, those 40-year-old men, like that is a really horrific figure. Where do these neighborhood differences come from? Well, populations who have high cardiovascular risk live in neighborhoods that have less high quality food. They have fewer places to exercise that are safe. They have vacant houses. They have environmental toxins. They have traffic. They have low economic opportunity, lower rates of economic security, higher rents as a proportion of their income. The less access to recreation. So these are not like things that are hard to understand. The one thing that is often overlooked is that these contemporary differences are things that were produced over the past 100 years, as opposed to happening by chance. One of the things my team and some other teams in Northeast Ohio have been working on now for several years are looking into how differences in the way that we financed housing as far back as almost 100 years ago in Northeast Ohio and other urban communities had a massive influence on restructuring our neighborhoods, such that an agency of the U.S. federal government, the Homeowners Loan Corporation, used color-coded maps to designate which neighborhoods were suitable for making home loans. And in Ohio, what our work found was that for any neighborhood in Ohio that had any Black resident at all in the 1930s, that neighborhood was 45 times more likely to be redlined, which meant that no one in that neighborhood who lived there, regardless of their race or ethnicity, would be able to get a home loan. And that extended there are some great stories from Northeast Ohio. Even the bank was not able to get a loan. Even the business wasn't able to get a loan in a red line neighborhood. So the bank couldn't get a loan from other banks to build a new bank. So this story is particularly shocking because then the flight of capital, like how you can't even go to a bank because the bank can't get a loan to build a new bank in your neighborhood. So you have really a total exodus of capital from many, many urban communities in Ohio. And we really haven't recovered from that. This is a quote from southeast suburb in Cleveland. About 2 years ago, a strong effort began to decrease the colored occupancy of this area and has resulted in the moving of 33 families, some of whom were moved at the city's expense. In each case, the removal of a colored family caused the occupancy of a white family in this neighborhood. There is also a tendency toward improvement in the physical appearance of the community during this same period. So this was recorded by one of the real estate personnel who was making the decision about whether to redline neighborhoods in Northeast Ohio. If we take that map of redline neighborhoods and we compare it to from 1939 and we compare it to the map of life expectancy in 2015, they look like the same map. It's not all bad news. This figure comes from CDC Morbidity and Mortality Weekly, and it shows the cardiovascular mortality gap across all ages for the past for about a 30-40 year span. And you see a couple of interesting things here. You see a point when in the 80s, cardiovascular death was relatively equal for men and women. And then we had this thing that happened where the diagnosis of cardiovascular disease in clinical settings, we got better at it for men than we were at it for women for a while, for about 2 decades. But then we had a bunch of research showing that was happening. Like we named the equity gap by sex and gender. And by naming it and working on it, we all but eliminated that gap 10 years later. Now we're seeing actually, like, if you remember the figure I showed before, we see that things are actually much worse now for men than they are for women. The new gap that's formed more recently. So my favorite report on what to do about health equity comes from the World Health Organization. this is, sort of plastered all over the WHO for the past 10 years or so. And they really make three simple points. One is to improve the conditions of daily living for everyone. Two is to tackle the unequal distribution of power, money, and resources. And three is to measure and understand the problem, assess the impact of action. And I think the nice thing about these three statements is that they're designed to apply all the way down to your clinic or your neighborhood, right? Like these don't have to be like the state of Ohio needs to improve daily living conditions or measure the problem and understand the impact of action. We can also measure how we're doing in our own clinics locally. So now that I've given this general overview, I'm going to leave you with a couple of reflection questions, and hopefully we have enough time to hear about Gotham's case and all of your thoughts. But I think these are nice questions to think about maybe throughout, like every week coming up. So how can learning about health equity influence the way you'll provide healthcare in the future? And this one, I actually think is the most underrated health equity question for health professionals, which is, in what ways are you already working to be sensitive to the needs of diverse and vulnerable patients? Because I think a lot of our work is already focused on this, but maybe we don't name or recognize it, or maybe we don't emphasize it in our clinical care. And one of the things that some of my trainees have shared at Metro, residents, fellows, and others, that ends up, so I said, you take like at least like 10 actions to address social determinants of health every day in your practice already. What are you talking about? I don't screen. My clinic doesn't do screening. I don't do any of this stuff. And I say like, well, don't you get those form requests for the home energy assistance program in the summer? Or don't you sign a paper that gives somebody a day off of work because they're ill, or excuses them from school? Yeah, of course. Well, all of those things are addressing needs that can be specific to diverse and vulnerable patients that you're doing all the time already. And maybe you just think of those forms as like a hassle, like you have an in basket full of 40,000 forms and nobody wants to look at them. On the other hand, like maybe it's as important as signing that form is just as important as signing the prescription for the antihypertensive. So I think one of the nice things about this series is that it's a real nice way for us to sort of open our minds to all the ways that we can improve equity and care for patients. I'll hand it over to Go.
Thank you, Adam. That was great. And I think these questions are things that we all ought to reflect upon. So any additional questions for Adam before we move on?
I have a question. Can you hear me?
Yes, Gary, go ahead.
Oh, thank you. So, Adam, I know it's a large portion of your discussion, and I respect it, and I appreciate the discussion, falls upon race. And I think here about other populations that are impacted, maybe even more so than race, to be considered. And one of those populations are the disabled. And there are multiple organizations, centers for independent living across the state of Ohio. And I can tell you the magnitude of outreach to those organizations is large. And my full disclosure is I am disabled. I'm in a wheelchair, and I've been in a wheelchair for 20 years. And I've been in the hospital quite a bit and receiving care, and I do my annual follow-ups with my doctors. And I can tell you I have experienced what you were talking about, health equity, and being not receiving the care that other people receive that are comparatively healthy or comparatively not as disabled as I. And I think it's generally because of national standards or guidelines that are followed for standards of care, don't incorporate, and the experience that the healthcare community does not have in treating populations of disabled individuals. So, and I do think that would be incorporated into your discussion, or it should be incorporated.
Thank you for that really important comment. Yeah, I'm reminded of a case narrative that I don't know was presented in ECHO series. It might have been in one of my other groups of a middle-aged man who was in a wheelchair, who was called up by the hospital and said, like, we really want you to get coronary artery calcium screening. He said, "Oh, this is great. Yeah, I feel like I don't get a lot of activity, and I want to know like what my risk of poor cardiovascular outcomes is." And so they gave him an appointment at the local imaging center, and he went to the imaging center, and the front door did not have a ramp. And so in order to enter the building, because guidelines on building design don't really specify exactly where the ramp has to be, you had to enter the building by the garbage and the loading dock, because that was the only place that this particular building had a ramp, and it's covered in trash and stones, and it's a steep grade to access the ramp. And he made an attempt. He was by himself. Drives, he's in a chair, and he made an attempt to get to the to get up this ramp, but there was like so much trash and stones and dirt that he abandoned, and he just went home, and he didn't get that coronary artery calcium screening. So I think like the ubiquity of these kinds of barriers for disabled persons is very, very clear. Hopefully we'll have some cases where we're able to discuss and reflect on like health equity strategies that are health promoting and disparities eliminating for disabled persons. But I think you're exactly right. Thank you for bringing that up.
Okay. All right. Well, thanks very much. I'm going to turn things over to Claire, give you some next steps here.
Sure. So thank you, Adam and Gotham, for presenting today. We appreciate it. On the screen, you can see the cardio.org website does have an archive of old echo clinics. If you're interested in going, it's open to anyone to view previous clinics. We only post the didactic, so the first kind of lecture part we do not post the case studies. You can log on to the website to do this current clinic, but we do keep it behind a wall just to preserve kind of the, feeling of this group. But you can sign on and watch it. The URLs are there. Next slide, Rick, please. Just a couple of reminders. After every week, we send a post-clinic survey that comes through our REDCap, which is our database system. You should have received it about 15 minutes ago. It comes from my email. It's a very quick, I think it's 3 questions. It's feedback on today's session. So you will get that every week. We ask that you fill it out. We give it to the subject matter experts next week so they can have direct feedback on how the session went. We are working on the case study presentation. I will send a schedule as soon as it's semi-finalized. I am still missing some cases from people, so if you have not sent them in, please do so quickly. And if you ever need to contact us, there is an echo@cardio.org email address, or feel free to reach out to myself or Andy. If anyone has any questions, let me know. Otherwise, we will see everyone next week.
Okay, thanks, everyone. See you next week.